Hello, I'm Donal McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today I'm talking to Emma Lads in the UK. Emma, you're one of an unusual group of people because you grew up in a GP's household. Tell me about your interest in medicine.
Well, I suppose you're right that growing up in a GP household just immerses you in it, and that's what you know. And I can remember every day after school going back to the GP practice and doing my homework there, waiting for my mum to finish, or going off in the car with her on home visits and waiting outside while she saw her patients. And I can remember the bottles of wine and the boxes of chocolates at Christmas, and I suppose all the cards from people saying thank you and how much she'd meant to them and what she'd done. And I think probably that influenced me far more about what medicine can do for people than I realised. And I'm sort of coming to reflect on that later on when I have my own patients. And I think it was really from that my interest in medicine was sparked, but it took a long time for me to recognise that, I think.
Now, general practice when you were growing up must have been quite different.
Yes and no. I think there were many differences, obviously. I mean, I think the kind of continuity that my mum had with her patients and the longevity of working in a practice for 30 years or so and working with the same group of partners for that length of time. I think that probably has gone in most cases. I think honestly, though, the values of general practice are still the same, and they always will be. And the desire to promote the principles of general practice, first contact access, free at the point of use, the continuity of seeing patients, being immersed in the community, being family doctors. All of those sorts of principles, I think probably are the same, actually. And we may practice them in different ways, and we may use technology and text messaging and emails, and we may have extra staff in the practice that my mum never had, but actually we're trying to achieve the same goals. And I think it's really important that we try and hang on to those, because I think that's who we are. And I think it's where the value in general practice is as well.
One of the big changes must have been in the pattern of home visits.
Yes, I think that's definitely changed. And it's really tricky, isn't it? Because we are very pressured. There is a lot of demand, and fitting in home visits on top of everything else is very difficult. That said, it isn't that we don't visit, and I know every practice and every area is different. I still very much do visit my patients at home, particularly the complex housebound ones, or the palliative patients as they come towards the end of life. And I think there's a real sort of additional value in doing that and seeing the context in which somebody lives. And I think it's a real privilege to be able to do that as well. But I do recognise that for a lot of practices, and for us actually every day, the sort of practicality of doing acute visits for chest infections or just some slight deterioration where people feel unable to get to us just isn't possible anymore. And we're very lucky in our area to have a paramedic visiting service who are very good and help us out in those kind of cases. And I think more and more in general practice, we're having to deal with the fact that we're having extensions to our team, and there are ways that we integrate them that are better than others. And I think knowing the people you work with, so having continuity within the paramedics who provide the visiting service, give me confidence in the quality of care we're giving to patients and allow me to interact with them more meaningfully. So I think there is the pattern has changed, but some of the complexities around visiting have changed as well. And those reflect some of the wider complexities, I guess, that we're seeing too.
Now, general practice wasn't your first career choice. You took a little diversion along the way.
Yeah, it's been a bit of a circular career path, that's for sure. I did medicine originally and then trained initially in plastics, plastic surgery, and loved hands, loved the business of sort of reconstructing after trauma. And then I suppose life gets in the way and you reflect a little bit on how long you might be in hospital for doing a training course and how little autonomy you might have over your life in that time. And I think I realised I wanted something a bit different. I've got many interests and probably too many. So I took a bit of a diversion over to the States and did a public health master's. And I spend a lot of my time teaching now, as well as doing a PhD part-time alongside being a GP partner. So I like being able to combine different things.
Now, tell me about your public health masters. That must have been fascinating.
Yes, and no, it was really interesting. I mean, I think the best thing about studying in the States is that actually there's much more flexibility and much more freedom over your courses, and you can tailor your degree to your interests. So, I mean, I did public health, but actually a large part of my time was spent outside the public health school, in the School of Policy, the Fine Arts Institute, taking all sorts of courses. So I learned a lot about leadership, finance, history, politics, far more so than I might have done if I'd just studied a public health degree in the UK, I think. And that's broadened my horizons and made me think about things in different ways. And I think that's really helpful for any doctor, but particularly somebody who's a bit more immersed in academia and thinking about service provision and development as well.
Public health in the States is very different to public health in the UK. I mean, it's not necessarily medical, so you must have met some very interesting people.
Yeah, I mean, my course had more than 300 nationalities represented on it, so it was fascinating. And people from all sorts of backgrounds as well, engineers. There were a lot of policy people, but also some some people who'd been sort of in the financial sector who wanted to come in and relearn skills to be able to apply them in a more meaningful, serviceful way. A lot of people who'd been in consultancy. So yes, fascinating people and people who are going on to do all sorts of different things as well. So definitely a lot of doctors who just wanted to learn a bit more about management or a bit more about public health in general. A lot of people who are going to do overseas work, and a lot of people who are going back home to their respective governments to work in policy, and public health overseas. So yeah, I mean, I think it was a fantastic opportunity and I was immensely lucky to be able to do it. So I think it's influenced me in many ways.
There's quite a contrast between the public health, epidemiology, quantitative side of things, and your current interest in narrative medicine. Tell us about your interest in narrative medicine.
I think again, I'm afraid it's one of those yes and no answers. So yes, there are obviously lots of differences and lots of differences between numbers and large data analysis and the business of stories. And I suppose what you come to realize more and more and what you reflect on is that actually you can do all the number crunching in the world and you can be the best analyst you're ever going to be. And I was never going to be that person. But unless you can sell the story of what those numbers mean and put it into context for people and give it some real meaning for individuals and or for policymakers, it doesn't matter. It won't go anywhere. It won't have traction. And I guess, I mean, that's where I realized the value of narrative. And I see that every day for my patients. Every consultation is a lesson in different narratives and interpreting them and trying to read people and trying to interpret their stories. And I think I've just been able to think about the application of that same process to research and policy and think about how we actually make that happen in practice.
Now, you've brought that into your own research work. Tell us about your research work and the doctor-patient relationship.
Yeah, I mean, again, it's quite varied. So I've been a bit scattered all over the place. So I did start off in large data analysis and have a number of sort of papers on that. But actually, more recently, since COVID, I started working in the early pandemic on patients who weren't getting better after COVID, who we come to recognise now as patients with long COVID. And my team did a lot of the early work interviewing people and running focus groups for these patients who just weren't recovering as expected, and the sorts of impacts that their illness was continuing to have on them. And really, we thought a lot about the changes to identity that they were suffering and the sorts of losses that they were incurring. They were having to give up work. They were really struggling with relationships, with families, with maintaining the same kind of lives as they'd had before becoming ill. And we started to think a lot about how they were actually interpreting that. And there was a lot of anger that they were expressing about the relationships that they'd had with a number of doctors. Initially, I think doctors were very focused on just treating COVID and dealing with the pressure of the pandemic. And a lot of these patients felt like they were being ignored, or a lot of them said they were being gaslighted. They didn't feel listened to, they didn't feel heard. And I suppose that started me thinking a lot more about the value of individual patient-doctor relationships and what we may bring to our patients' lives, or how we may harm our patients' lives without necessarily, or when we don't give those relationships due attention and due respect. And we've always known that. I mean, it's nothing new. But there have been changes that have happened with the introduction of technology. So how have we diluted the relationship, or how have we enhanced it with text messaging or with emails or asynchronous encounters or e-consult, all those online forms that you have to fill out as a patient that then tell you can't see your doctor, you have to go to A&E instead. There's all sorts of different influences coming in. And it is no longer a sort of single patient GP relationship in many cases. We're including pharmacists, physician associates, paramedics, all these extra people in that whole encounter. And the lack of continuity as well, the sort of increasing turnover and pace of things. And so I've been looking at some of those impacts and the sort of effects that has on individuals, so both the doctors and the patients, but also more widely on the system as well. So I think some of the time what patients are looking for is an ability to connect, to find some kind of or somebody who will hear them, who will bear witness to what they're going through. And often what we've done is to design a system now that is much more transactional in nature and doesn't provide that sort of support for somebody. Yes, it might give you antibiotics, or yes, it might give you a fit note, or yes, it might allow you to have a referral. But a lot of the time, it doesn't allow you to build up that kind of relationship that might have just meant you had a sense of security, a sense of being held, a sense of being seen. And that in turn drives demand, I think. So I'm looking at that in a bit more depth.
In a recent book review, you wrote that you were saddened by what you thought was happening to general practice.
I think there are many things that sadden me about it. I think what saddens me most is that I have to fight harder and harder to be the sort of doctor that I want to be, and that I think patients would like me to be as well. And I suppose, if you like, that is a more old-fashioned sort of traditional general practitioner. And it's not that I'm anti-technology. I love being able to text my patients. I think it's fantastic. I think I like to be able to listen to people, and I like to be able to give them the time, and I like to be able to see the same person again. And I think we haven't designed a healthcare system that values those things. We've designed a healthcare system that values metrics and objective outcomes and access targets. And it undermines those kind of attributes that contribute to relationships. And I think that's what saddens me, that we're having to fight harder and harder and work harder to make those relationships and to make care meaningful, to make care caring in lots of cases. And I think there are some easy things that would improve it. And it's just sad that we haven't been able to see that, really.
Clearly, you've thought about this a lot, and some of the principles that you've talked about and clearly hold dear, like continuity of care and the doctor-patient relationship, we're struggling to maintain those. Looking to the future, how would you design general practice? What do you think is going to happen in general practice in the future?
It's the $10 million question that we ask every salary doctor in our interviews when we're trying to appoint somebody, and nobody knows. And I don't know either. And I think we are lying if we can kid ourselves that our healthcare system can continue as it is. I think my worry about general practice and what I want to avoid is a multiple tier system where there is a very stretched level of general practice, perhaps overseen by GPs, but not run by GPs, where actually demand is very, very high and the kind of quality of care is lower because people are pressured, they're stressed. It becomes more transactional because inevitably when systems are under pressure, they resort to that because it's safer and easier and more measurable. And then there will be a second or a third tier of general practice, which will probably to some extent be private, whether that's resourced through insurance or resourced through individual patients. And we're already seeing that now. And consultations are 20 or 30 minutes in length. I'm sure patients get the chance to be heard, to tell their stories, to really feel like somebody is there for them. And that sort of care in a good system may mean that the number of referrals are not as high, the number of investigations aren't necessarily as high, the sort of pressures are less, and so it's a nicer place to work in. So I suppose that's my fear. If I were to try and design it, what do we need? I think we need to be able to fund GPs properly, actually. I think there's an integrative ability that comes through years and years of training, that gives a GP different skills to some of the additional roles who are highly valuable in general practice, but do different things. And I think at the moment there's an assumption that we can break down general practice into tasks and give it to different professions. So the pharmacist can do one thing and the physician associates can do another thing, the paramedics can do something else, the nurses can do something else, and they all can, and they can do them very, very well and in a very skilled way, but somebody has to put the pieces together. And actually that somebody at the moment is a GP, but at the moment the way the funding is determined, it's very difficult to use specific pots of money to fund GPs. And actually what I would do is say, well, you know, GP, the partnership model is terribly efficient. It probably is the most efficient way of running a primary care system. Actually, what we ought to do is just put money into the core contract again for partnerships so that they can employ the staff they require to meet the needs of their local community. Everywhere is different, and we shouldn't expect a one-size-fits-all model. It won't be like that. And trying to force it to be like that will just generate inefficiencies and frustrations, and we'll lose staff, and you'll devalue it. And I think actually recognizing that partners who are invested and have a responsibility to a patient list actually are in it for the good of their patients 99% of the time, and we ought to trust the profession again.
Emma, thank you very much for sharing your vision of general practice. Clearly, the profession is in good hands for the future. Thank you very much indeed.
Thank you.